شريف we start. شريف معنا.
Good evening, everybody. It is a pleasure to have everyone for this first Orthopedics Monday of the new universitary year. We will talk this time with the upper limb group, the GMM group, about upper limb entrapment neuropathies. We will have the honor to have as moderators Dr. Nida Al-Mahdi from sous and Dr. Hatem Safi from Tunis, who are two experts of hand surgery and nerve surgery. And we'll have the honor to have as an invited speaker Dr. Vincent Martinel, who will speak about this new science, which is the gene, and who we would like to thank to have accepted the invitation. We will talk first. I have the pleasure to talk about what to do in front of failed carpal tunnel release. Then Dr. Amin Hajem will talk about a rare case of retropectoralis minor brachial plexus entrapment and what to do. We'll have the mini conference of Dr. Vincent Martinel about the genervology. Then Dr. Ali Abdelnader will present a case about posterior interosseous nerve entrapment. Dr. Ashraf Kharat will talk about a very interesting rare variant of dorsal sensory ulnar nerve branch entrapment. And finally, Dr. Rami Ben Mheni will end by presenting Queen's syndrome with a very atypical etiology. So before beginning, please, I would like to recall, please put all your micros mute unless you are going to speak. I have the pleasure to begin. We had a 37-year-old woman who was right-handed. She was an assistant of a dentist surgeon. She had no medical history, but she had paresthesias of three first digits since 2 years in the right hand, and it was becoming permanent since 3 weeks. She didn't have any dropping of objects, and she was treated medically by a rheumatologist who referred her after infiltrating by corticosteroid to our consultation. When examining the patient, we didn't find any Thenarian muscles hypertrophy, no vasomotor signs. We found a good Kaplan-G score, a harmonious pinch, but a subtle weakness at pinch test. And we find all positive irritative signs, and especially a Durkan sign, which is here in the photo. And her median nerve was S3M5. When analyzing the AMG, we can see then that the sensory velocities are diminished. They are at 31 at left and 39 at right, and she had a bilateral severe carpal tunnel syndrome. So to sum up, we are with a woman who has 37-year-old, and she had severe bilateral carpal tunnel syndrome with no motor impairment, and she was resistant to medical treatment. So we performed a minimally invasive carpal tunnel release using the Wallant anesthesia. So the first 3 weeks, we had a partial regression of sensory signs, but at the third month, we had the persistence of some nocturnal paresthesias. At 6 months post-operative, we had the appearance of fatigue in the right hand when writing and during manual tasks. So at that point, I'm asking everyone to answer. What would you do? Would you refer the patient for a neurology consultation? Would you do an electromyogram? Would you repeat the complete clinical examination? Would you do an ultrasound, or would you revise surgically this carpal tunnel syndrome recession? So if you can answer, we'll see the results of the poll. So severe sensory. Okay. So most of you would repeat the complete clinical examination, and some of you would ask for an EMG, and a minority would revise surgically this carpal tunnel decompression. So this is exactly what we thought. So we now discussing about what to do and how to do it. We have we did a literature review, and we focused on this new review, this and these guidelines in the efforts European open reviews, how to manage failed carpal tunnel decompression. The most important is to talk to the patient and to see if there is no improvement or if there is recurrence. To differentiate these two notions, we have to look for a free interval, meaning if the symptoms have regressed or not. If the symptoms have regressed and then appeared, then we had a free interval, which can be caused by an abusive neurolysis, maybe causing a true recurrence of carpal tunnel syndrome by scar adhesions or epineural fibrosis, as we can see here. If we didn't had a free interval, meaning the patient was going very bad since the surgery, he never did well after the surgery, we have to look for local signs when examining the patient. If the local signs, meaning tinel sign and Durkheim sign, are persistent, it means we did an incomplete release. If they newly appeared, we have a new TNL appearing after surgery, it means that maybe we did a nerve wound and a perioperative complication. Second, in the physical examination, we should look for proximal signs. Do we have other nerve compressions, and especially in the cervical area or lacertus area? Third, we have to look for an underlying severe neuropathy, especially diabetes. And we always have to keep in mind that patients who have workplace accidents or occupational illness are the patients who are never going to recover, are the patients who are always going to complain. So in this review article published in 2024, the other investigations that should be performed, as most of you said in the poll, should be the EMG, which is very important, but not the most important. Imaging should be first ultrasound and MRI, but the most important is talking to the patient, seeing the history and examining the patient. And the most of all, we should not hide from ourselves. We should not hide the complication to ourselves. And we should not say to the patient, everything is going well, everything is going to go well. We should be honest with ourselves and with the patient. So at physical examination at 6 months, let's get back to our patient. We did a thorough physical examination. We didn't find any trophic disorders. We didn't find any irritative syndrome at the wrist, at the carpal tunnel. We found a scratch collapse test at proximal anterior forearm. So the scratch collapse test is a brutal collapse of the external rotation, resisted external rotation, when triggering the entrapment zone that was here, the lacertus fibrosus. But we can use it in any entrapment. So moreover, cervical spine was normal, an X-ray and examination and biology was normal. Finally, we did an EMG, as you all suggested, and we found that the velocities, the sensory velocities were better at the right hand. And we asked the neurologists if we had an entrapment at the elbow, but even if we had a scratch collapse test, we didn't find any electrical signs of elbow entrapment of median nerve. So at this point, what would you do? This is not a median nerve compression at the elbow. For you, this is a Lacertus syndrome which must be treated. The EMG must be repeated. We should look for another cause of nerve entrapment, or we should just wait and see. So as we can see here, it's controversial. Most of you say that it would be a lacertus. It's only 37% of the participants, but all the participants are not agreeing about what to do. So it was a lacertus syndrome, which which we have. Just to recall, the lacertus is an aponeurotic expansion issuing from the biceps tendon and goes to the forearm aponeurosis. And after cutting, we see that it's very narrow to the median nerve, so we can easily imagine how it can be compressed. The diagnosis is based on a clinical examination, and here I am citing our expert, Dr. Vincent Martinel, who is here with us today. And the Haggard triad was described, and it's decomposed in three signs: the loss of strength in the FPL and FIP, the notch sign, which we can see here in the forearm, which can be replaced by pain in the anterior proximal forearm, and last of all, a scratch collapse test at the cutaneous projection of the lacertus, and this sign is very sensitive. So usually, the imaging and EMG are normal in this syndrome. Why? Because it is a dynamic syndrome, and it is a syndrome which causes only occasional ischemia, meaning that EMG would be abnormal only in late stages of severe neuropathy. And the same thing in imaging, we would have imaging signs only if we have sufficiently severe nerve compression. So this patient was having a multiple crush syndrome described by McComas since 1973, which is defined by an entrapment of a nerve at least two sites, which will cause him to be more vulnerable, and his antegrade and retrograde axonal exchanges will be abnormal. And the most frequent one that we should look for are cervical spine plus carpal tunnel syndrome and lacertus plus carpal tunnel syndrome when examining a median nerve. I'm citing a second time Dr. Martinel, who described this surgery. So we performed a mini open lacertus release under Wallant anesthesia, and we found the lacertus cutaneous projection using the tripod method defined by the biceps, the medial epicondyle, and the lacertus fibrosus. So it is a very easy surgical procedure. We cut the lacertus fibrosus, and as you can see, just before the surgery, on perioperative imaging, we have a weak FPL and FIP tendons, which couldn't do resisted flexion, and just after the surgery, before closing the wound, we have a resistant 5/5 MRC flexion of FIP and FPL. So it's not magical, but it's because of the occasional and dynamic nature of this compression, which was not severe at the elbow. So that's why the patient could recover. So the evolution, the last follow-up, we are at 18 months. We had no recurrence of syndromes, and we had an improvement, especially of fatigue and irritative symptoms. So maybe the take-home messages of this case are that carpal tunnel decompression that doesn't work should lead us to do a rigorous investigation, to look, especially when talking to the patient, for a free interval, and we should question ourselves for what we did and how we did it. We should do a thorough physical examination, and we should always look for double crush syndromes that can be a cause. of the failed decompression, and we should always have good information of the patient throughout the process. Thank you.
ايش؟ ما خزنت لا والله خزنت ب6000 انا على قد حالي، بس خزنت بدري من ظهرك الان مع المناديب ولا مرافقين ما ذهب علي كمان، وقد انا زعل والله على قد حالي.
دكتور عبد الله, please keep your mic. دكتور عبد الله خالد نصر, please keep your mic mute. دكتور عبد الله. It's okay.
We start the discussion about this case. حاتم.
ميكرو يا حاتم, ميكرو.
Je te remercie, Sherif, pour cette belle présentation. Donc, on va voir, est-ce qu'il y a des questions? Est-ce qu'il y a des questions parmi les présents?
Oui. Est-ce que c'est possible de poser une question à Dr. Sherif?
Bien sûr, Moaz. Oui, bien sûr.
Voilà. I try to ask him in English. So, can we say that the patient had carpal tunnel syndrome now when we knew that the compression of the median nerve was under the lacertus fibrosus?
So when we saw the patient, she had all the signs of carpal tunnel syndrome. She had a pseudotunnel sign in the anterior wrist. She had the fallen sign. She had by the way, we always perform the scratch collapse test even in distal compressions. So we found the scratch collapse test positive and the EMG was positive. So and by the way, we had looked for lacertus fibrosus when the patient came, and when she first came, but we didn't find any signs. So I think all these arguments were in favor of carpal tunnel syndrome.
Okay, thank you.
Please, can we remind that for all the participants, just keep your mic mute when there is a discussion and where there is a lecture, please, for all the assistants, please. Okay, Dr. Nidal, excuse me, sorry.
No problem.
Yeah.
So I think that it's really a very good clinical case, because we see that the lacertus fibrosus tunnel syndrome is a new entity in our practice, but it's more frequent that we can believe it. So as Dr. Sherif said, it's always recommended to make a double check to check whether there's or not a double crash syndrome, even if there's an evident carpal tunnel syndrome. And in this case, he checked for that. He didn't find it in the beginning, but perhaps the contribution of the compression, of the proximal compression, wasn't very important in the beginning. And when he released the carpal tunnel syndrome, the entrapment was more evident. So for the residents, I always ask them to always check whether there's a proximal compression, cervical or in the lacertus fibrosus point.
Thank you, Dr. Mahdi. We totally agree with you. It's more frequent than we think, and the detractors of this syndrome who think that it is something that we are imagining They say that we are finding lacertus fibrosus lesions everywhere. Dr. Martinel will talk about this better than me, I'm sure. But I think it resolves the problems of many patients. To look always, it's the message, to look always for a compression of lacertus fibrosus associated with carpal tunnel syndrome.
See if next case.
So Dr. Hajim will talk about retropectoralis minor plexus, brachial plexus entrapment.
Hello, everyone. The presentation, our case is provided by Dr. Fakhreddin Triki, and I will present 70-year-old girl. She had paresthesia of the right hand during exercise and writing. She has been suffering for 5 years ago. She had consulted medical specialty, neurology, psychiatry, but the patient still suffer, no etiology and no improvement found. She consulted on July 2023. The first exam found no deficit. The patient still suffer from paresthesia during writing and pain in the with the writing. First exploration, we have done EMG, which came normal. Sonography for thoracic outlet syndrome, also normal. And the patient still suffer and no improvement with medical treatment. On September 2024, the patient still suffer. New EMG, which conclude to neurogenic involvement of the first dorsal interosseous. We our clinical exam do the scratch test. We begin for the pathologic upper limb, as shown as this video. We stimulate the infraclavicular with positive scratch test, supraclavicular with negative scratch collapse test, the wrist and the elbow, which are negative. Scratch collapse test is positive only in infraclavicular. The scratch collapse test in the left arm, which negative for along the upper limb, supraclavicular, infraclavicular, the elbow and the wrist, all are negative. And this is the conclusion. The right infraclavicular is negative, is positive. What diagnosis at this stage can we thoracic outlet syndrome, psychiatrist, pectoralis, other. As we see, there is the half of the participation conclude to pectoralis minor syndrome, and the other half is divided between thoracic outlet syndrome and other. There is a scheme, anatomical cadaveric scheme to this is the coracobrachial tendon, the coracoid, the pectoralis minor, the brachial plexus with the arteria and the venous, axillary vein and axillary artery. By this scheme we can, what next? A review of the literature. We have found this article which speak about pectoralis minor syndrome. We can found an injection of lidocaine as shown as this article help it with sonography, and this is the microneedle. See that like this by helping this article with anesthetic block with 1% lidocaine hydrochloride of the pectoralis minor. This is our sonography by Dr. Shawqi Dabesh, our radiologist. We can found the microneedle attached to pectoralis minor. This microneedle and the infiltration. This infiltration, we found a marked improvement for 2 days, but the patient still suffer. What should we do for the next? Review of the literature. We have found the role of botulinum injection in this syndrome. This injection is also guided by sonography, and in which we can individualize the artery, the vein, and the plexus with the pectoralis. Botox infiltration of the pectoralis minor was done to our patient, and the patient this time have regression of symptoms for 2 months, but the suffering is still relapse, and the patient refused a new Botox infiltration. What should we do next according to the patient is still suffering? We have found a look for the surgery, which consists tenotomy, the insertion of the pectoralis minor at the coracoid process. This is an article which with arthroscopic release of the pectoralis minor tendon from the coracoid, we can find the bibliography and the photography of arthroscopic. This is the pectoris minor and this is the viper with tenotomy. This is the arthroscopic vision of our patient. This is the pectoralis tenotomy, and the yellow part is the part of the plexus brachial, and this is the coracoid. As we see, this is with this yellow, the plexus brachial, which was liberated. The anatomic scheme with the coracoid process in which inserted coracobrachial and pectoralis minor. We found immediate regression of paresthesia. The patient is ameliorated with marked improvement. After this surgery, protocol of rehabilitation with the passive movement, then active assisted mobilization of the scapulothoracic. This is the exam of the patient, which scapulothoracic was stabilized, and in first time we don't have the video, but the patient was instability of the scapulothoracic. A review of the literature in which we found some bibliography which speak about the forgotten pectoralis minor syndrome. The syndrome is alone or accompanied by neurogenic thoracic outlet syndrome. The pectoralis minor syndrome, 90% of cases is truncal or peripheral neurological signs not involving the brachial plexus. In the clinical examination, we found no other compression related to thoracic outlet syndrome, no headaches, no neck pain. tenderness over the pectoralis minor muscle, shoulder and axillary pain, tenderness over the coracoid process on palpation, and impairment of the stability of the scapulothoracic articulation during arm elevation. In conclusion, pectoralis minor syndrome is the most overlooked condition in the management of thoracic outlet syndrome. It should be considered first in cases of failed initial thoracic outlet syndrome surgery. Then the question, should routine section of the pectoralis minor be performed systematically during thoracic outlet syndrome surgery? And thank you.
حاتم.
Thank you very much for this presentation. I think it may suggest some questions. Is there any questions from the presence? Perhaps I can begin with this question. How do you explain the instability of the scapulohumeral in the pectoralis minor syndrome?
Je peux répondre ça, Hatem.
Comment? Qui fait?
Je peux répondre, Hatem.
Oui, oui, bien
Oui,
sûr,
bon.
c'est Fakhreddine, bien
Donc,
sûr.
les dyskinésies scapulothoraciques, l'un des éléments d'étiologique des dyskinésies scapulothoraciques sont les petites anomalies neurologiques, les petites atteintes neurologiques qui atteignent donc une dyskinésie. Et ces atteintes neurologiques, quel que soit maintenant, au niveau du grand dentelé, ou bien au niveau du trapèze, ou au niveau dans le syndrome donc, de compression, thoracic outlet syndrome, ou bien dans le syndrome pectoral, il y a toujours des petites anomalies, ces petites anomalies neurologiques qui entraînent une dyskinésie entre la scapula, du fait de la douleur, hein, et la dyskinésie au niveau de la scapulothoracique. Et donc, tu vas avoir, donc, dans les mouvements d'élévation antérieure, tu vas avoir une scapula qui va s'ailler en arrière. Et l'un des éléments de l'émission, c'est l'absence de cette régression immédiate de symptomatologie lorsque le problème est corrigé. Mais c'est décrit parmi les causes de dyskinésie scapulaire. C'était bien détaillé, c'était très, très bien détaillé par Hassan.
Bassem El-Hassan. Bassem El-Hassan.
Bassem El-Hassan, ok.
Justement, je voulais poser la question parce qu'on pense toujours au serratus antérieur pour la stabiliser, pour les dyskinésies de la scapula, mais en fait, tous les muscles qui stabilisateurs de la scapula peuvent être responsables de dyskinésie.
Il y a même, parfois même certaines ruptures, on a remarqué une fois, dans certaines ruptures de la coiffe, on peut avoir une dyskinésie. Il y a même aussi dans les atteintes de disjonction acromioclaviculaire, on peut avoir une dyskinésie.
Absolument. Est-ce qu'il y a d'autres questions dans la salle?
Our guests are asking for translation. Dr. Nidal, you have to translate what it was said now about thoracic joint. What was said now by Dr. Fakhreddine Trikis was very interesting. If you want to translate for our guests speaking in English.
Okay, so he said that these particular dyskinesia of the shoulder and the of the upper arm is associated or is seen when we have some entrapment of the finest nerves of the proximal shoulder, and so it may be a symptom of the entrapment nerve. So it's associated. It's not a consequence of this entrapment. If I can make a summary of that. I have a question, Dr. Ramzi, if you don't mind, regarding the surgical technique. So it's a question to Dr. Tricky regarding the technique that he does with arthroscopy. So when you make the release of the the minor pectoralis, what is your key anatomical landmark to ensure the complete sectioning of the pectoralis minor tendon while safely avoiding the medial and the lateral cords of the brachial plexus? Because we know it's very important to preserve them. I'm talking about safety. And could you describe for us that are not performing this arthroscopy, how to make the difference, or what is the appearance of the tendon versus the surrounding neural structure in your endoscopic view? Because it's not very common to see in an arthroscopic view the nerves and the tendons.
Pour ma part, donc, avant de s'attaquer à l'endoscopie, il faut faire un peu de cadavre, hein. Donc,
Of course.
oui, c'est fait du cadavre avec l'âme. C'était dans le cadre de préparation de faire débuter sous endoscopie. Et ce travail
Exactly.
de cadavre avec l'âme m'a aidé pour réaliser cette technique-là. Le fait de voir l'apophyse coracoïde et de libérer la partie inférieure de l'apophyse coracoïde, de voir le coracobiceps et par la suite de voir en dedans le petit pectoral, ça facilite énormément donc la tâche. Et je vous assure que la vision du plexus brachial, elle est beaucoup plus intéressante par endoscopie que par la chirurgie à voie humaine. C'est beaucoup plus intéressant. Et ça, on voit très très bien, on vous a montré là maintenant. On voit le latéral cord, donc on le voit très très bien. Le tronc secondaire antéro-matexaire, on voit très très bien. On voit très très bien l'endoscopie. Et ça actuellement, c'est à la mode. La libération de la neurolyse sous endoscopie, que ce soit pas pour le pectoral, même pour le thoracic outlet syndrome, etc. Donc, c'est une tendance. Mais c'est une technique safe. Actuellement, j'ai vu même dernièrement une technique de libération du nerf axillaire sous endoscopie. Et c'est une technique qui est réalisable. Il suffit de se mettre au cadavre là, et c'est une technique safe. Et on voit mieux, beaucoup mieux par endoscopie.
Par voie ouverte.
Par la chirurgie, on voit toujours on voit d'un saignement, ça saigne. Par l'endoscopie, il y a de la pression. Et on voit vraiment, c'est safe. On travaille sur l'hypotension. Et c'est vraiment, on ne voit pas de saignement. C'est joli la dissection du plexus sous endoscopie, hein.
Très bien.
Very nice.
Autre question peut-être par rapport au protocole de rééducation?
Le protocole d'éducation, c'est spontané, matin. C'est vraiment, ça vient tout seul, hein. On cherche un petit peu à renforcer un petit peu la scapula-thoracique, c'est tout, hein. Et puis le reste, ça vient tout seul, hein.
So there's no difference between this technique and the traditional transaxillary approach when you make the first rib resection, for example. You have exactly the same rehabilitation protocol. There's no specific movements to avoid,
Non,
to allow.
pas du tout, pas du tout.
Okay.
Juste des mouvements, madame, la flexion, extension, des mouvements d'élévation, c'est spontané, ça vient tout seul. Et puis on met rapidement les malades dans l'eau et ça vient tout seul.
Très bien.
If we can translate the answer for our other participants.
So Dr. Tricky said that there's no difference between the classic approach and arthroscopic approach regarding the rehabilitation protocol. We just allow the patient to make his natural movement, and we advise him to swim, as I understood, quickly to have restoration of the movements.
Thank you, Dr. Mahdi.
Bon.
Great.
Sharif, next.
So now we are going to have the conference of our guest speaker, Dr. Vincent Martinel.
Hi everybody. I'm very pleased to be here with you, and I want to thank the organization for this great event. The next question is I prepare the slide in English and maybe the oral conference in French, but do you prefer I do it full English or I talk in French?
If possible, full English if possible.
For our guests.
I maybe will be a little bit longer, but I try. Okay. You can see my screen?
Okay.
Yes.
It's good? Okay. So thank you. And I want to invite you in a new world, in a new clinical examination called dynervology. And we will focus on the upper limb entrapment. I've quite no conflict of interest. And I'm one of the main author of this French comics translated in English with an amazing team here. We got Elizabeth Hager, Thomas Apart, and Benjamin Ferenbach tweeting about Lacertus syndrome. And I really want to thank Dr. Ferenbach, which is a French guy, younger than me, but he's a genius. Why? Because this is the man who invited this term of dynervology. And what does it mean? It means we studies the dynamic component of nerve disease, and it's how to understand dynamic nerve entrapments in the upper limb, lower limb, and on other anatomy spaces. For an example, you know that if you have a patient with lateral elbow pain resistant to medical treatment since several months, you will think first to epicondylitis, tendinosis disease, or you will look for a bone lesion that in this young adolescent patient. But most of us don't think about the nerve. And it's very important when you are not sure and when you got a failed treatment to think why it's not the nerve. And another example is after surgery. You did a spine fusion, a first rib resection, a nice shoulder surgery, and the patient still have pain and you don't understand. You do X-ray, you do MRI, and where is the problem? Think about the nerves. And the dynamic component is important. We are a human being, we are walking, we use your arm, and movement is life. And the movement is allowed because we've got in your body mobile tissues like muscle, fascia, aponeurosis, and these structures can induce repeated microtrauma on nerve. And the dynamic entrapment is the opposite of static entrapment. And the best example of a static entrapment is the carpal tunnel syndrome. And don't forget that the nerve is the messenger of the motor action and the vector of the sensitive information. And most of the nerve do the both. And the nerve doesn't like the pressure. They hate them. They are fragile. And as we said, we don't think about the nerve enough in our daily practice examination. And this is an important reflection. You only find what you are looking for, and you're only looking for what you know. And this is a big sentence from Claude Bernard. If you don't know what you are looking for, you don't understand what you find. And here is a danger, because you can't treat what you don't understand. And you maybe, for most of our patients, we think about diagnosis, but it's maybe not the good one. And in these cases, what are good patient? We don't know, and we have to do a complementary test and examination. And we've got patients with normal EMG, ultrasound, RMI, which are normal, or said, oh, this is a tantezopathy. Then RMI always shows something, you know. And what is your answer to your patient? You have nothing. It's in your mind. This is psychosomatic. You have a fibromyalgia, or this is an algodystrophy. But maybe it's not. And the main danger in medicine is the dogma. The dogma, what the master said, you have to kill the dogma and you have to think different. The master is the patient. don't forget, your masters are your patients. And you got the English translation and the French text. And that's right, that dogma enacted under the authority of the master are often long-lasting. Don't forget this. And if you know that the nerve can cause of pain with normal EMG and complementary examination, you are on the good way. And how to perform a dynavologic diagnosis, it's full clinical examination. You doesn't need second or complementary examination. And the most incredible gift I had last 10 years is the Haggard triad, and we'll talk about it. Well, Elizabeth Haggard described a triad for the diagnosis of all nerve entrapments, with looking at a pain at a trigger point, a muscle weakness, and the scratch collapse test. And you need the three together to be sure of your diagnosis. And why nerves are irritated by repeated microcompression? Because there's a saturation effect on the nerve. And there are the épines, peripheral irritative tone. And we think that there's a problem in the intraneural hypoxia that altering axonal transports and causing then neuropathic symptoms and pain. And of course, you said, yeah, let's do EMG and we have the solution. But what is able to detect an EMG? You know that it's not 100% of success. It's, for example, in carpal tunnel syndrome, it's 85% of sensibility. That means that 15% of true carpal tunnel have normal EMG. Don't be aware with EMG. And what is important in dynavology, it's what Benjamin Fehrenbach called the garden hose theory. Here is the example of a static compression, like carpal tunnel syndrome, and you need that the water is the flow is very low because there's a static entrapment. But the problem in dynamic entrapment is that the compression is during the movement, and when you do EMG at rest, EMG is normal, and that's explained why. In the first case, there was a normal EMG and no abnormality at the elbow was found. Now, I invite you to kill the dogma, and I invite you in my operating room. It's a surgery of lacertus under Wallant, and I'm with the patient. She has a plier just under the lacertus. We test the pinch. The video is good. Okay. And we didn't talk about the testing of flexor carpi radialis, which is very important in complement of FPR and FDP2. We just cut the lacertus and look at the difference. There's an immediate strength recovery. The pinch is excellent, and the power recovery of flexor carpi radialis is quietly amazing. And you got diagnosis, and you are sure of a dynamic cause. So, which nerve can be affected by dynamic compression? The solution is all the nerve. Many nerves at the upper limb, but also at the lower limb, and it's important to know. This is a draw of the upper limb, and these are the main dynamic entrapment sites. You know, of course, carpal tunnel syndrome, cubital tunnel syndrome, and Guillaume, but there are also different ones that I will show you. This first view is the three main sites of medial nerve entrapment, from proximal to distal, with the lacertus fibrosus, which is in fact a dynamic pronator teres syndrome. More distally, entrapment under the flexor arch of flexor superficialis fingers, and distally at the carpal tunnel. The main entrapment site for ulnar nerve are two at the cubital tunnel, horseborn ligament, flexor ulnar carpis fascia, and the last one at the Guyon's canal, but you have to know that there are 3 zones in the Guyon canal, and I will try to talk about it just a little bit later. And for the radial nerve, of course, the most famous is at the middle, the radial tunnel syndrome, at the Froze arch. But there's 2 other sides which are important. One at the arm, what is called the Lis lateral intermuscular syndrome, between the triceps and the brachialis muscles. There are entrapments at this side. And the last one is entrapment of the sensitive branch of the radial nerve called Wartenberg syndrome at the emergence between brachioradialis and extensor carpi radialis longus. It's usually at 8 centimeters above the radial styloid. Let's talk about Hagert's triad. I explain you that you need 3 checking to have the good diagnosis, the pain, selective muscle weakness, and the scratch collapse test. And in a recent paper, Elizabeth Hagert explained this approach and explained how it can be used for all nerves entrapments. Pain under local pressure. You got an example here for a Lacertus syndrome, but you can do it everywhere. And we got the cartography of the trigger points. And you are looking for a pain at the Lis, radial tunnel syndrome, and other points in your clinical examination. And this is a patient who was assessed for shoulder pain, recalcitrant to medical treatment. And you look that we complete all the shoulder tests like Neer, Hawkins, O'Brien by the trigger point, and you saw a trigger point on the pec minor. Maybe most important than scratch collapse test is to understand selective muscle weakness. This is the Seddon classification. And of course, it's easy when you see a patient with complete paralysis, but the challenge in dynervology is to be able to make the diagnosis with stage 4. That means that the patient have a weakness. It's not a paralysia or a paresis. It's a weakness. And sometimes it's poor or high strength, and it's what's difficult in diagnosis. But you have to learn, and to find them. And this table is a real gift by Hagert family, Carl Gohan, and his daughter Elizabeth, because they checked for every level of entrapment of every nerve, the muscle you have to test. And for example, if I take Lacertus fibrosus, you need flexor carpi radialis, FPL, FDP2. And it's the difference with a real anterior anterosseous syndrome, where you have a weakness of FPL, FDP2, but a normal strength of flexor carpi radialis. I want to show you this example on a cubital tunnel. This man has a good strength, but is weak. He's weak on the FDP5 and ADM, abductor GT midi. And when you compare and do the bilateral examination, you can reveal the weakness. Here is the weakness I test for radial tunnel syndrome. And you see the difference, and I ask the man to resist on his extensor carpi ulnaris. And this is the triad of testing on lateral intermuscular syndrome with the weakness of the extensor of the thumb, of the index, and of the wrist. And you see the complete recovery during surgery under Wallant after release that confirm the dynamic compression. Here is so the sum up of clinical tests to do. And now let's talk about the scratch collapse test. It's an amazing test, and maybe there's a different name because in some publication you can find a sensory collapse test. It's a nerve irritation test. And it was first described by the team of Susan McKinnon in 2008, sorry. And it's a high sensibility and specificity, especially for carpal tunnel syndrome and cubital tunnel syndrome, maybe more efficient with after a big learning curve, but more efficient than Fallen or Thielen sign. Here is an example. I show you that you test the strength of your patient, and if you there's a sensitive stimulation. Yeah, here is an example with patient. You test both carpal tunnel, both cubital tunnel. I test the left lacertus resist, and on the right one there's a collapse. And the patient have to understand the problem, and you try again and again. And you can do it without touching the patient. Just the blowing is enough to stimulate, and you see the collapse. And if you put cold on this zone, it's like an anesthesia of the skin, and the scratch collapse test become negative. And thanks to this, you improve the sensibility and the specificity of the test. And if you warm up and wait a little bit, it will work. And the pencil test, it's not used in daily practice, but it's important for the physiopathology of this test. I show you. I make this point. I ask the patient, I test the patient, ask the patient to scratch herself. It's not working. I gave her a pen, and with the pen, she scratched. So we think there's a retro control between the two hemipart of the brain. And that's why auto scratch by a patient is not possible. And sometimes we've got whole patient with shoulder disease or plexus disease, and it's not possible to do the scratch collapse test on the upper limb, but you can do it on the lower limb. Here is a patient with a left carpal tunnel syndrome. He has reverse shoulder prosthesis. That's why I don't do the scratch collapse test on the upper limb. But if I ask him, try to resist and your ankle doesn't touch together, I just blow, and there's a collapse on the lower limb. So it's a good tip and trick if you have patient with big problem of shoulder. And another trick is what we call the lacertus antagonist test. You saw the weakness, I medialize the pronator teres, and the patient resist. Loss, resist, and the patient is able to see and feel the difference. It's new test, important to use, and that show you the dynamic part of the entrapment. And in the second part, we change the hand by kinesiotape, and thanks to kinesiotape, you can test your patient, and you will see the difference in this video. And you ask to your patient. I just want to you ask your patient to keep the kinesiotape, and it's it's the first part of the treatment. Okay. Alors, a few words about lacertus syndrome, but as we said previously, some of our colleagues said this is a real bullshit. It doesn't exist, and because do the diagnosis, it's not easy and makes time. That's why in this article, Elizabeth Haggard and his team try to explain the difference between a carpal tunnel syndrome and the lacertus syndrome, but it was explained previously. You have to understand that the most common symptoms are the weakness of the K-pinch, Tenarian pains that are usually not present in the carpal tunnel syndrome. Sometimes there are right cramps, and patient have a problem of numbness then don't talk about pins and needles, but numbness. And you got really arm and shoulder pains, which are the consequence of a lacertus syndrome and not shoulder disease or thoracic outlet syndrome. And don't forget what was said previously about double crush. Double crush with concomitant carpal tunnel syndrome and lacertus syndrome is very often, and it's maybe what happened in the first case described this evening. Something very amazing. We talked about dogma, and we learned that maybe neurotic pains goes all way anterogradially. But there was this article from a Japanese team, very interesting, and they create the term of retrograde neuropathic pain. I want to show you this case of patient who came with shoulder disease. She is unable to have anti-flexion and mobilization with her left arm. She had physio, kine, infiltration, and I test her, and she has a weakness of and a complete lacertus syndrome with a complete triad. I put the tape, I test, and thanks to the tape, I test her shoulder. And what is amazing is to see that with a tape, she's able to move her shoulder, and without, it's painful. And we can't actually explain it, but we can see it. So this patient, maybe she was told that she was mad, that she has fibromyalgia, but if you are looking for a dynamic entrapment problem, you will find. And a short explanation I tried to do about this case. Another one case is sometimes we see frozen shoulder, and we think that frozen shoulder are adhesive capsulitis, but sometimes it might be arthrogenic muscle inhibition, and maybe lacertus syndrome and other dynamic entrapment syndrome can generate an arthrogenic muscle inhibition. We talk about cubital tunnel syndrome, and the muscles targets I show you in the previous video. But what is very important is that sometimes, thanks to the scratch collapse test, you can check which is the real level of entrapment of your nerve. If it's very proximal or very distal. And I saw a patient 6 months ago, and I had a scratch very distally, 4 centimeters under the medial epicondylitis. I checked it in my computer, and when I did the release, I decided to have a look more distally than usual, and I saw the entrapment where the scratch collapse test was positive. It's amazing. Guyon's tunnel, maybe I'm not enough time, and I have to pass this video. And pectoralis minor, you had a nice example previously. And just show you that the testing of the biceps without and with the taping, that show you the dynamic regression. These 3 examples, it's to show you that when you have a dynamic entrapment, you have to treat the dynamic component, and you can use tape, kinesiotherapy with neurodynamic technique, the hydrodissection to confirm the immediate recovery of the strength after release. In conclusion, you have to understand the cause of the pain, because you learn that the pain in the shoulder, in the elbow, and the wrist is the consequence of tendinous or muscular tears, osteochondral tears, and sometimes it's nerve because it's a radicular disease. And sometimes you have got patients and you don't understand their problem, and you push them in the wrong diagnosis, and stop to do it. Stop. Because if you find a pain that persists during several months with good treatment, maybe it's a dynamic entrapment. And second message is that when you got patient with normal EMG, it doesn't mean the absence of nerve entrapment. Think different. And thanks to deniability, you can reset your clinical examination. You have to kill the dogma. It's very frightening to reset your clinical examination, but it will be very important for your patient. Clinical examination is the first key, and don't forget that additional tests and examination are additional. The magic table of Elizabeth Agert, keep this table in your mind, use it every day. Actually, my daily practice. I've got this QR code in the last slide, but 6 video how to do a complete clinical examination of dynavolology in the Lacertus syndrome, and I invite you to flash the QR code. And if you want to learn more, it's in French language, but you are welcome. Thank you, everyone. I was very pleased to present you this conference. I hope it will help you, and I'm waiting for your question.
Thank you very much, Dr. Martinel, for this very clear and valuable update of our knowledge. It is really very interesting. The scratch collapse test is really very underused here. Your conference should interest most of all. Donc, for me, the first question, if you find 2 or 3 zones of entrapment, do you treat them in one time, or a different surgery? You begin with the first, and after you do the second?
It's a good question, and there is no one answer. I think that at the beginning, you have to keep aware, because if you start to treat a patient with normal EMG, maybe at the beginning of experience, you have to see the results after one. I talk about unusual entrapment, lateral anterior muscular symptom. And with experience, maybe you can combine surgeries. Of course, in daily practice, if you are quite sure there's a double crush with carpal tunnel syndrome and Lacertus syndrome, you treat them both. If you are sure that you've got a flexor arch entrapment, you do a bigger incision and you treat both carpal tunnel, Lacertus syndrome and flexor arch. And in my experience, what I learned that it's in very severe cubital tunnel syndrome with muscle atrophy and cubital crow who appears on the cubital entrapment at the elbow. Sometimes you test them and you find a scratch collapse test at the elbow, but also at Guyon canal. And EMG is always normal. And I had several cases like this. I asked to my friends, Elizabeth Agert and others, it's your patient, what do you do? And sometimes I treat both in the same time, because you want the faster recovery when you got a severe ulnar nerve entrapment with atrophy of the first interdorsal muscle and problem on the intrinsic muscle of hand. And I think it's a good thing. And maybe sometimes patients have not a recovery because they had a double crush with a Guillain canal, but normal EMG.
Thank you. Is there any questions?
Yes. Thank you, Vincent, for this clear and interest conference. I want to ask you the triad of Haggard. When you have an entrapment of sensitive nerve, why or how to search weakness? There's no weakness with like Wartenberg test, for example.
Yeah, Wartenberg, there's no triad for Wartenberg, and there's quite no triad for saphenous nerve, because those are sensitive nerves. You're right. And that's why it's difficult to do a surgical treatment with just this clinical examination. And that's why I talk that actually we use the Haggard triad and the taping, and it's a tetrad. We've got four tests. And of course, with the Wartenberg syndrome, you will have the scratch, the pain, and the tape. And you try to find how to put the tape. Your patient leave your office with a tape, and you ask them to call you or send an email 2 weeks after and explain you how their life is better or not. And take this time to do the good choice in the treatment is important. Maybe at the beginning of experience, surgery was quickly and easy, but thanks with taping, that you can put on the leads, on the radial tunnel, on the pec. Patient try this treatment, explain, and they come back and is with the tape. I have 50% pain less. I'm better, but I have allergies, and I don't want the taper. I want the surgery.
Right.
You keep your. Oui.
The real explication of the tape. How you explain the definition of wake with the tape.
We are not inside, and we don't know. But one of the explanation is that the taping. I thought at the beginning that we change the orientation of muscle, but maybe the best explanation is that the tape acts like a aspirator.
Okay.
If you have a good tension, there's aspiration of the skin and under skin tissues, and that's help to partially treat the entrapment.
Excuse me.
Thank you.
You keep the tape for a few days?
Yes. In my personal practice, I create QR codes. And I gave them for my patient. I've got a QR code for Lacertus syndrome, cubital tunnel, and the LIS. And I invite patient to see. It goes to a video, and the video explain how to do your self taping when you have to do sport, when you have to work, and to test and try it. Treat your problem yourself.
If I may ask a question?
Yes, it's possible to have a question for Dr. Vincent.
Yes, please.
Thank you for the presentation. I want to know, as you know, that the compression of median nerve at the stage of the elbow and the Lacertus and the ADF are so close to each other. So with the scratch collapse test, can we differentiate or separate the level of the compression even when it's a dynamic compression, we can't find the diagnosis with radiologic exploration?
Yeah, I just take this. You see my slide?
Yeah.
At the superficialis arch,
Yeah.
when you got just Lacertus syndrome, you have a weakness of FDP2, but when you test FDP3, the strength is complete. And sometimes you compare FDP2 and FDP3, and thanks to this, you have the diagnosis of Lacertus syndrome. In case of compression at the flexor arch, there's a weakness of FDP3.
So when we okay,
and in the end, the tape there's a distance of 3 fingers between the Lacertus and the flexor arch, and you can compare the you mark it with a big stilo, and you can precisely do the scratch at the Lacertus level or the flexor arch level, and you also can compare with the tape at one level and the second level.
Okay, thank you.
But weakness testing is different.
Okay, thank you.
Thank you, Dr.
We have
Martinez.
time, Dr. Safi, if you have time, a very quick practical question.
Yes, please, Sharif, allez-y.
To our participants, to me also, when we find Lacertus syndrome, when should we absolutely operate it? And when should we maybe try corticosteroids, because there are not there are controversies about the treatment. We are sure that the surgery gives good results, but we don't know much about medical treatment.
There is no scales of severity in this syndrome. We know that if you do nothing or conservative treatment, 20% of Lacertus syndrome will heal, but with surgery, 80% will heal. So it's we can say that it's not a new pathology, but we discover this pathology recently, and sometimes you have patients who see 20 doctors, have a pain during 5 years, are in pain centers, and you decide to do surgery directly because they have a long pain story with them. And in case of pain that began less than 6 months, I think we can try conservative treatment. It's important. No surgery without any ultrasound examination. It's very important. I didn't tell it because I have ultrasound in my office and I check all my patients, but sometimes it's cysts, tumors, and it's important to say no. There is no static compression. And the second one is that electromyography is most of the time normal, but sometimes with neurologists who are aware with Lacertus syndrome, if they are looking for in myography suffering from flexor carpi radialis, they can find severe signs, and maybe it's an indication to go directly to surgery.
Thank you.
Thank you very much, Dr. Martinez. We are in loss of time. I think we have to pass to the second session, or we will have a break. I don't know.
No, not break. We continue.
Okay,
We continue.
we will pass for the avec with Ali Abdelnader for his case. Ali, are you here?
Hello, hello everyone. Yes, I'm
Allez-y.
here. Can you see? Yes, no.
Not yet.
Can you see now?
Not yet, Ali. Yeah. Yes.
Yes, okay. So good evening, everyone. Let me present you this case. I'm Resident Ali Abdelnader, and I have the pleasure to present this clinical case, which was provided by Dr. Hatab Safi, who I thank. So we are a person of a 35-year-old man. He's a banker, right-handed. He had the progressive onset of paralysis of finger extension, noticed 7 to 10 days ago. The physical exam showed a mass of 2 centimeters in the proximal third of the right forearm. As we can see in the videos, here we have an active extension possible. And we have a finger extensor paralysis. So an EMG and an elbow ultrasound were requested. The EMG showed the partial contraction block of the pin in the upper third of the forearm. But the ultrasound found the synovial system of the elbow measuring 29 millimeters, which is exerting a mass effect on the adjacent sensory branch of the radial nerve. So we are in front of 35-year-old man, his banker, progressive onset of paralysis of finger extension, partial conductive block of the pin, and the synovial system of the elbow. So this is an anatomical reminder. We see the division of the radial nerve giving deep and superficial branch of the cubital fossa. The line in blue represents the bifurcation level. So the posterior intraosseous nerve, known as pin, is the deep motor branch of the radial nerve, supplying all the extensor muscles of the forearm and hand, except for the brachioradialis and the extensor carpi radialis longus, mentioned in yellow. So those 2 muscles are innervated from a direct branch of the radial nerve. That's why wrist extension remains possible, but with a radial drift, because the pin innerves the extensor carpi ulnaris, and when this branch is compressed, it leaves the extensor carpi radialis longus unopposed. So, as we can see with the red arrow showing the synovial cyst compressing the branch of the radial nerve. The patient underwent surgery and the synovial cyst was removed. So this video is 45 days after surgery. As we can see, there is an improvement of finger extension. This is 5 months after surgery. There's a big improvement. But the index finger is not at full recovery. And this is 5 years after surgery. We can see the total improvement of finger extensions. So coming to the discussion part, let us start first by reviewing the posterior interosseous nerve syndrome. So weakness or paralysis is the dominant feature. There is a possible wrist extension, but with the radial drift due to direct fibers innerving the extensor carpi radialis longus. There is no sensory deficit. The EMG can find denervation, partial conduction block, an action loss, an acute space occupying lesion, post-traumatic lipoma, synovial cyst could be the cause. Complementary tests are needed to determine the cause. As we can see, multiple cases of posterior interosseous nerve compression from synovial cyst have been reported in the literature. So as a conclusion, the pin syndrome is a rare nerve compression condition in the upper forearm. Paralysis of finger extension despite preserved radial wrist extension is indicative of pin syndrome. Compression caused by external factors like synovial cyst could exist. Complementary tests are needed to determine the cause, EMG, ultrasound, and MRI. And thank you for your attention.
Thank you very much, Ali. It was very clear. Is there any questions? Because we are in loss of time now.
Don't worry, Hatem. It's very interesting. I'm learning a lot this evening. So you can take your time.
Thank you, Ramzi.
Okay.
Is there any questions? Or we'll pass for the next. Sharif,
Yes.
would you?
We will have now the honor and the pleasure to welcome Dr. Iman Ma'loul, who is a senior radiologist and who will present with Dr. Ashraf Khalad a variant of dorsal sensory ulnar nerve branch entrapment. Thank you, Dr. Ma'loul, for being with us.
So I need to thank everyone for this opportunity. And today I'm going to share with you a case of Dr. Luz with coordination with Dr. Ma'loul of pain in the ulnar side of the distal forearm. We are presenting a case of 47-year-old female complaining with pain in the left distal forearm on the ulnar side. She has no history of known trauma or other pathologies, and she came with an X-ray that showed no anomalies. When examined, the patient presents pain and tenderness alongside the flexor carpi ulnaris, but no pain when palpating the pisiformis. She does not present any swelling or neurological deficit. The diagnosis for this case was the flexor carpi ulnaris tendinopathy. We thought about an ulnar nerve entrapment in the Guillaume's canal, but the pain was proximal to the canal with no neurological deficit, episotracheal joint pathology or an early arthropathy, but it's not an articular pain. So the most likely diagnosis is the flexor carpi ulnaris tendinopathy. Given the diagnosis of ulnar wrist flexor tendinopathy, we decided to perform an ultrasound-guided infiltration of the person. This approach was particularly encouraged by the atypical presentation of the tendinopathy, especially the absence of antizopathy as a mean to better visualize the tendon and optimize the expected results of the infiltration. But the ultrasound shows a normal appearance of the flexor carpi ulnaris tendon with no signs of inflammation. So I'll hand over the floor to Dr. Ma'loul, our radiologist, who will show us and explain the patient's ultrasound and findings.
Okay. Good evening, everyone. It's a real pleasure to be with you today. I'm a radiologist currently working in a private practice. This is an axial ultrasound view obtained approximately 4 centimeters proximal to the wrist. Here we can see the ulnar nerve before the cutaneous branch separates. Then you will notice this cutaneous branch fluttering under the flexor carpi ulnaris. Its course under this carpi ulnaris tendon is moderately narrowed, comparing with the other sides, as illustrated on this slide, which shows a clear difference in measurements between the left and the right side. This is an actual static ultrasound image that summarizes the key anatomic structure seen in this video. This is the ulnar nerve and its branch, the flexor carpi ulnaris, the pronator quadratis, and the flexor digitorum profundis. On this video, you can see the cutaneous branch of ulnar nerve, which appears swollen with a rounded shape, but without loss of its internal fascicular architecture. This is a still image clearly showing the swollen and the rounded shape of the cutaneous branch of ulnar nerve. On the contralateral side, you can see the cutaneous branch thinner, less rounded, and without any signs of swelling. On this slide, the video is oriented in the distal proximal direction, opposite to the previous one. You can see here the cutaneous branch joining the male ulnar nerve. And here you can see the needle approaching the cutaneous branch of ulnar nerve with a tip in contact with the nerve. Then we injected 2 cc of xylokine, followed by 1 cc of diprostine, and the response for the xylokine test was positive, confirming the suspected site of nerve irritation.
To understand more about this case, we need to freshen up our anatomy first. So, as we all know, the dorsal-cutaneous branch of the ulnar nerve is the terminal rami of the ulnar nerve. It originates from the medial side of the ulnar nerve at the distal third of the forearm and passes underlaying the flexor carpi ulnaris tendon. And thinking of what can cause the neuropathy of the dorsal-cutaneous ulnar nerve, we found that it was first reported by Stafford at 1922 in 2 patients as a result of compression by tight wristwatches. Henderson also reported on the first isolated dorsal-cutaneous ulnar nerve neuropathy caused by handcuffs due to pressure of this branch against the ulnar bone, or the tendinous portion of the flexor carpi ulnaris muscle. McCarthy and Nelbev found the surgical procedure an anomalous branch of dorsal-cutaneous ulnar nerve, an example of Kaplan's anastomosis. And Lucas, on the other hand, found dorsal-cutaneous ulnar nerve lesion related to cystic proliferative synovitis. But Resch described an occupational neuropathy called Price's palsy due to combination of flexor position of the wrist and fast repetitive pronation of the forearm in front of code reading machines. In this circumstance, the dorsal-cutaneous ulnar nerve was injured between the distal ulna and the flexor carpi ulnaris tendon, as it is in our case. When looking for Price's palsy in PubMed, we found only one article from 1985, and it was the original article published in the New England Journal of Medicine. It shows that the syndrome is caused by repetitive and fast pronation of the forearm and ulnar flexion of wrist, causing the entrapment of the nerve between the flexor carpi ulnaris and the distal ulna or the pronator quadratus. It was first seen in Price's when using code reading machines, as it demanded the repeated described movement of the forearm and the wrist. The surgical exploration done by wrist showed a body appearing dorsal-cutaneous branch of the ulnar nerve as it came under the flexor carpi ulnaris, which is like the aspect that we have shown in the ultrasound. To understand more this phenomenon, Keisha and all done a cadaveric and clinical study of 40 cadaveric upper limbs and 13 cases of compression of the dorsal cutaneous ulnar nerve. In the cadaveric or anatomic study, they concluded that this branch was up to injury during wrist movement as it crossed between the flexor carpi ulnaris and the distal ulna. The clinical study indicated that this syndrome presents with the following set of clinical features. They showed local tenderness in a fixed localized tender point, abnormal skin sensation, decreased grip strength due to pain, increased pain with resisted ulnar deviation after radial deviation of the wrist, with positive tenile sign, no palpable masses, and restricted range of motion. So we can see that it can mimic tendinopathy of flexor carpi ulnaris. And the treatment, they found that non-surgical treatment can be used as a local block or infiltration and also surgical release. Going back to what we did, is the ultrasound a good tool to explore this branch of the ulnar nerve? We found that Locorel answered this question for us, and it showed in this study that high-resolution ultrasound can always identify the dorsal cutaneous ulnar nerve, and it allows precise mapping and exploration of this neuropathy. Back to our patient. After this analysis of the literature, we repeated the anamnesis and clinical examination, and we found that she had tingling and hyposthesia. And also, flexion pronation when doing the ultrasound has exacerbated her pain. So what we did, as Dr. Malou said, we did an ultrasound-guided exalocaine test first, and it had the dramatic and immediate pain relief. After that, we did an ultrasound-guided infiltration of the dorsal cutaneous branch of the ulnar nerve near the suffering part. And we are now at 6 months of follow-up, and the patients still have full recovery. In conclusion, the entrapment of the dorsal cutaneous branch of the ulnar nerve may be rare, but is undoubtedly underdiagnosed. Its signs might mimic those of flexor carpi ulnaris tendinopathy, and the ultrasound offers an effective and straightforward means of assisting the diagnosis. Therapy can involve anything from infiltration to a surgical release procedure. And thank you, everyone.
Thank you very much for this excellent presentation and for this excellent case that shows the importance of clinical exam and what the ultrasound can give us for to have the exact diagnosis. Thank you, Dr. Maloul, for this explanation, and I'll pass to the presence. Is there any questions? Effectively, in the clinical exam, it is very important to precise the zone where is the tingling and the sensory problems. It will and if the EMG is normal, will pass to ultrasound, which can give us questions, an anatomical anomaly or a mass which compress a nerve, like the last case in the posterior anterossus nerve. Is there any question? If not, we'll pass for the next presentation. It is the presentation of the case of Dr. Fakhreddin Triki. It will be presented by Dr. Rami Ben Mhenni.
Okay, do you hear me?
Yes.
Absolutely.
Okay. Good evening, everyone. I'm Ram bin Mahani, and I'm glad to present you a unique case about the ulnar nerve compression syndrome managed by Dr. Fakhreddin Triki. So our patient is a 37-year-old male with no significant past medical history. His symptom began suddenly about 10 days prior to consultation, following a minor right wrist trauma occurred while slamming a door. Since then, he presented with progressive clawing of the fourth and fifth digits with no sensory deficits. The radial and ulnar nerve pulses were palpable with good tissue perfusion in the hand. For the exploration, we performed a radiography showing no anatomical anomalies, so we performed an OMG showing signs of peripheral neurogenic involvement limited to the territory of the deep terminal motor branch, with neurogenic atrophy of the hand anterossus muscle. The echography revealed appearance of a synovial cyst within the hypotenar compartment measuring 13 by 9 millimeter, just inferior to Gaines canal and the pisiform, showing intimate contact with the ulnar nerve. As a management, we performed a surgical exploration of Gaines canal by means of a 5 centimeter zigzag incision in the volar ulnar region of the hand and the wrist. The exploration was deepened in layers, and it was observed that the compression was caused by a synovial cyst of around 1 centimeter. We can see clearly the transparent cystic tumor compressing the deep motor branch. The cyst was resected along the neuralizes in the canal, and finally, the skin was sutured after hemostasis verification. These are the postoperative photos at 2 weeks showing a healing scar with no neurological deficits. At the 5-year follow-up, the patient showed a well-healed scar, complete correction of the ulnar clue, good muscle trophicity, and good functional outcomes with no signs of complication or recurrence. We conducted a brief review of literature and found that ulnar tunnel syndrome, also called Gaines syndrome, is a compressive neuropathy of the ulnar nerve at the wrist, occurring at the level of Gaines canal. It's the second most common site of ulnar nerve entrapment following the elbow. She and McLean divided Gaines canal into 3 zones, each associated with specific patterns of ulnar nerve compression. The first zone is located proximal to bifurcation of the nerve, and it's responsible for mixed motor and sensory symptoms, as shown with the green circle. The second zone surrounds the motor branch, and it's responsible for motor-only symptoms. And the third zone surrounds the superficial sensory branch, and it's responsible for sensory-only symptoms. Our case corresponds to type 2 of She and McLean classification. The symptoms can include pain and paresthesia, weakness to entering sex. Physical examination can find clawing of ring and letter fingers, muscle atrophy, tiny signs, weakened grasp, weak punch, fromage signs, gene signs, and waterbank signs. The incidence of Gaines syndrome is not well documented in the literature. However, several risk factors have been identified, including repetitive wrist movement, vibration, pregnancy, and obesity. It's also frequently observed in cyclists, a condition often known as handlebar palsy. Many causes have been reported in the scientific literature and can be divided into 7 different groups, including tumors such as ganglion cyst, lipoma, giant cell tumors, repetitive trauma, adjacent vascular enlargement, metabolic diseases, anatomical variation, degenerative diseases, and idiopathic conditions. According to several studies, ganglion cysts are the most common cause of Gaines syndrome, and it's responsible of 30 to 40% of cases. Another key point to keep in mind is the possibility of hypotenor Hamad syndrome, which can present with similar symptoms, but it's a completely different diagnosis requiring a vascular management. In fact, the hypotenor Hamad syndrome is a vascular condition where repetitive trauma to the hypotenor eminence damages the ulnar artery, causing reducing blood flow to the fingers. It is characterized by pain, coldness, color changes, ischemia, paresthesia, and sometimes palpable mass. Its diagnosis requires a high level of suspicion and careful clinical examination. Exploration play a crucial role in confirming and diagnosis the syndrome and identify the exact site of compression. It can include electroneuromyography, which is the neurological examination of choice to locate the compression, radiographies and CT scan to look for fractures, MRI and echography looking for gangliosidosis, lipoma, etc., and Doppler ultrasound or arteriogram to screen for vascular pathology. Treatment options depend on symptoms severity, duration, and etiology. An organic compression, for example, in our case, ganglion cyst, identified on imaging is an indication for surgery. The goal of surgery is to compress the ulnar nerve by opening the roof of Guy's canal and removing any compressive structure. Early decompression offers better postoperative outcomes, especially for motor and sensory recovery. In conclusion, Guy's canal syndrome is a rare and often underdiagnosed condition. Diagnosis is challenging due to variable clinical presentation. Physical examination, electrodiagnostic, and imaging studies are essential to localize the lesion. Ganglion cysts are the most common cause of ulnar nerve compression at the wrist, and early decompression and cyst removal leads to better functional outcomes. And thank you.
Thank you very much, Rami, for this excellent presentation. Thank you, Dr. Triki, for this case, for sharing this case. Donc, your conclusion is very clear. Phase to Guyon's syndrome, we have to demand an EMG, but also an ultrasound and other exploration function of what we suspect. Is there any question in the cell? Any question or commented?
Maybe the take-home message of that Dr. Benhamni said, exploring the ulnar nerve when it is entrapped in the wrist should be usual, because the entrapment, the spontaneous entrapment, is less frequent than in median nerve in wrist, and we should always look for an etiology before operating.
Absolutely, absolutely. I don't know if we had enough time. I prepared the conclusion, but it will take me 8 minutes.
Yes.
I don't know if I can present it or.
You can present. We have time.
Okay. Then I share my.
You can share your screen.
My screen. Okay. Do you see my screen?
Not yet.
Aye, aye.
Excellent.
Thank you very much. What's happened? Thank you very much. I will read. If not, it will take a lot of time. Entrapment neuropathies. Entrapment neuropathies are among the most frequent causes of localized nerve disorders. They occur when a peripheral nerve is compressed within a narrow anatomical space. This may be a canal, a fibrous arch, or a tight passage between muscles and bones. Depending on severity and duration of chronic compression, there will be nerve ischemia, localized or diffuse demyelinization, or finally axonal degeneration. The clinical manifestation will be sensory symptoms, motor impairment, or a combination of both. It is theorized that patient sensory complaints parallel is to pathologic neural changes, progressing from intermittent paresthesia to persistent numbness. Knowing the sensory and motor areas of the limbs is key to recognize where the nerve is compressed. It is also important to remember the concept of double crash syndrome. When a nerve is compressed in one area, it becomes more sensitive and more susceptible to damage at another level. The cause is the disruption of transport within the nerve fiber. Studies have shown that problems in the neck or thoracic outlet can make the nerve more vulnerable to compression in areas such as the carpal or cubital tunnels and vice versa. At the level of the upper limb, the most common compression neuropathy is carpal tunnel syndrome. Proximal compression of the median nerve can occur higher up, but in this case, tingling and numbness are also felt in the thinner palm, as the palmar cutaneous branch is affected, whereas it is not in carpal tunnel syndrome. For the cubital nerve at the elbow is the most common location of compression. Other compressions near the elbow are much less common, but should be considered. At the wrist, the nerve can be compressed in Guyane canal with different clinical manifestation depending on whether the branch is superficial or deep. For the radial nerve, compression can occur proximally before the branching of the wrist extensor nerves, resulting in paralysis of wrist and finger extension. When the compression occurs more distally, wrist extension is usually preserved and only finger and thumb extension is affected. Finally, higher up, the plexus brachial itself can be compressed at the level of one of the three anatomical triangles of the thoracic outlet. Patients usually complain of diffuse pain involving the neck, shoulder, arm, and sometimes the hand. Paresthesia, especially in the C8-T1 distribution, are often present. Diagnosis remains first and foremost clinical. Taking a good history is essential. We look for risk factors such as diabetes or hypothyroidism, repetitive movement, postural habits at work, and often limb position while sleeping. Symptoms are often characteristic: tingling, numbness, burning pain, usually nocturnal at the beginning, then persistent during the day. When compression continues, patients develop weakness, cramps, and sometimes visible muscle wasting. During clinical examination, several key points should be systematically assessed. First, check for any decrease in sensitivity within the nerve's sensory territory. This can be evaluated using the monofilament test or the two-point discrimination test. Next, look for the Tinel sign along the entire course of the nerve. Perform provocative tests that increase pressure on an already compromised nerve, either by applying direct pressure over the nerve, by joint flexion or extension, or by asking the patient to contract the muscle suspected of causing the compression. Then carefully assess muscle strength, as weakness can provide valuable information about the level and severity of compression. Finally, don't forget the stretch collapse test. It's still underused, but in selected cases, it can be very useful in identifying the exact site of entrapment. Good clinical examination can often be enough. For carpal tunnel syndrome, the CTS-6 score is a sample clinical tool. If it is above 12, the diagnosis is very likely and EMG is often unnecessary. Electromyography is a powerful tool when it shows prolonged latencies, reduced conduction velocities, or conduction block, confirming the site and the severity of compression. However, it is operator dependent and sometimes limited, especially in dynamic compressions or anatomy complex regions. Excuse me, that's the slide for electromyography. Donc, you see here latence, distal latence, and here the reduction of velocity, of conduction velocity. Imaging can then be helpful. X-rays to detect cervical rib or clavicle malunion, ultrasound to explore the entire course of the nerve dynamically and identify masses or anatomical variants, and MRI for plexus brachial and differential diagnosis. Speaking of differentials, they should always be kept in mind, particularly cervical radiculopathies, metabolic polyneuropathies, and the well-known double crash syndrome. Treatment depends on severity. Early management is key to prevent irreversible lesions such as muscle atrophy and loss function. Mild forms are usually managed conservatively. Rest, activity modification, normal nocturnal splints, anti-inflammatory medication, corticosteroid injections, or physiotherapy. But when symptoms persist or deficits appear, surgical intervention become necessary. Nerve release, injection, excision of compressive lesions, or neurolysis in case of fibrosis. Each entrapment site may have its own specific surgical approach, such as carpal tunnel release or ulnar nerve transposition. In summary, entrapment neuropathies are the most common form of localized neuropathy. Their diagnosis is above all clinical. Supported when needed by EMG and imaging. Early treatment is crucial to prevent irreversible damage. And finally, we must always keep in mind the possible differential diagnosis from radiculopathies to metabolic neuropathies, as well as the double crash syndrome. And thank you.
Thank you, Hatem. I think that's the end. And you stop sharing your screen. And okay. and we have to take a photo for all the participants, for all the participants. Then you make your video. Okay. I take a photo. Another one. All the participants. Thank you very much. Thank you very much for all. Thank you, Vincent, d'être parmi nous. Merci beaucoup, Vincent. Merci tout le monde.
Merci pour
Bilal,
l'invitation.
merci Zubair, merci Hatem.
ما كملتش
Merci tous les participants. On se verra dans un mois.
Merci tout le monde.
Ok, merci
À
beaucoup.
bientôt. Bonne soirée.
Merci.
À bientôt.
شكرا.